everyone, and welcome to this EUPATI webinar. Our theme today will be registries. We will have two presentations today, and I guess, and I hope, enough time for discussion, questions, and answers. I'll give you a brief introduction from our side. My name is Wolf C, and I will be hosting this webinar. I have been working with EUPATI since its start. I'm a physiologist and psychologist by training, retired, but I'm still fairly heavily involved in the IMI education and training projects on behalf of Bayer, which is one of the consortium members of our public-private partnership. Today we'll have two speakers. First will be Klaus Berger. Klaus is a neurologist and epidemiologist and professor of epidemiology and social medicine, and he heads the department or the Institute of Epidemiology and Social Medicine at the University of Münster in Germany. He received his medical degree from the Ruhr University in Bochum, incidentally, which is my home university also, in 1987, and he got his postgraduate trainings in public health and a master in epidemiology from the universities of Bielefeld in Germany and the Harvard School of Public Health in Boston. His scientific focus is on the epidemiology of neurologic and psychiatric diseases and health services research in population-based studies and patient registries. Since April 2017, he is the chairman of the German National Cohort, which is a very large prospective cohort study in Germany, which involves more than 200,000 participants. The second speaker is Lara Bloom. Lara is the International Executive Director of the Ehlers-Danlos Society and is responsible for global raising awareness of rare and invisible diseases, and she's specializing in the Ehlers-Danlos syndrome, hypermobility spectrum disorders, and other disorders related to that. Lara manages and coordinates medical collaboration, raising funds for research, and she focuses on the global progression of EDS and HSD. And Lara is all over the place. She speaks and lectures to medical professionals and as a patient expert supports specialists in the field. And she regularly works with umbrella organizations and bodies in Parliament. She's also a member of the Patient Empowerment Group for Rare Diseases. Now it's over to Klaus to start this. Klaus, the floor is yours.
Thank you, Wolf. Good afternoon from the University of Münster in Germany out to you all, wherever you may be. I took the first part to illustrate to you some principles of registers in terms of methods and what it could be. So if we start from the basic, the first question is, what is a register? I guess many of you do have an answer, and I'm pretty sure these answers will differ. So let me give you a clear definition, which the 4 points you see here are components of most of the definitions about registers, which might vary according to textbook or publications you might have checked. An important issue are the first two. Those words in the definitions that are most important are set in italic on this slide. A register is a systematic collection of standardized data. So the two keywords, the two buzzwords here are systematic and standardized. They should illustrate and tell us that someone has thought about what types of questions or data items will be collected, and several people have agreed that they will do that identically. Next 2 points, within a defined population, comes to the question who will be asked or from what type of patients or individual we will assess data. And the most important point is the last one, for a specific purpose, and I'll come back to that interpretation, what specific purpose might mean in a moment. There have been different publications on what quality criteria for registers could be. And I've allowed myself to add questions and quotes at the end of each of these points. Defined source population directly relates to the point we just saw. Defined means what is the source population in terms of method that gave rise to the cases, or putting it more simple, do we have an idea of how many cases we will ask and how many people are this population these cases live in or come from? And the second important point, did we assess all cases? Completeness in numbers, completeness in data, all items documented, or next point, correctness of documentation, the amount of missings, open fields in the standardized data collection, typos that might occur, or empty questionnaires from participants that should have answered things. All these are criteria for the quality of data assessment. And finally, to reduce the amount of recall bias, that is specific influences by the, if you're over 50, you know that problem, by the ability to remember things that are way back in the past and to correctly report them now, is real-time assessment or almost real-time assessment within the short period of time after an event occurred, for instance, or after something has happened. There are three major types of registers. Many of you probably have heard or access or even work within an epidemiologic register. These always have a defined source population given, for instance, by the inhabitants, the population of a total country, of a district, or of a state, for instance, the city of Münster or the state of North Rhine-Westphalia here in Germany. A second major type are clinical registers. They always have a patient reference and usually refer to the treatment setting. This could be a hospital or a group of hospitals treating patients with a specific disease, and or an outpatient setting where patients with a specific disease are treated and where they are collected and assessed and recruited for a clinical register. And finally, there are different types of other registers for various purposes, and I will come back on one of the next slides. What is the purpose of an epidemiologic register? In general terms, it's to assess the incidence of a specific disease or a group of disease within a defined population. And the epidemiologic cancer registers, for instance in Germany, but also in other European countries, are this type of register. The incidence of different cancer in the state of North Rhine-Westphalia would be a clear example for an epidemiologic register. Usually these type of registers analyzes temporal trends. Does the incidence of lung cancer among women aged 40 plus increase? And does the same cancer in their counter male parts decrease as it is observed currently? For instance, regional distribution of cancer cases within the source population, the defined area, to identify potential hotspots for specific cancer for instance, those close to a nuclear plant or a garbage waste facility or whatever. Another instance are outside of the stroke area, stroke registers with the population relation. There's one only in Germany. There are others in France and the Netherlands and even in Austria. They also assess the incidence of stroke, maybe their subtypes, treatment locations, temporal trends, and so on. If the completeness of case ascertainment, that is the coverage of the source population and completeness of case ascertainment is very high, then this type of register is able to analyze and provide also numbers on the prevalence of the diseases assessed. Clinical registers are very frequent, based on one or more hospitals or group of hospitals, or even nationwide. For instance, in the large area of quality assurance of treatment and care processes, in most countries, some type of quality assurance, for instance, for specific operations, in birth clinics, in the departments of anesthesiology, or in Germany, for instance, in the area of stroke, are existing and ongoing. Their purpose is to assess quality indicators, for instance, for stroke treatment, to allow a benchmark comparison among those hospitals or facilities that participate in this clinical register. An observation over the last 20 years is that the participation in such a register only contributes to improvement in most of the quality indicators that are assessed, and that is improves treatment for patients with stroke or with specific cancers. In the clinical cancer registers, they are based on those hospitals or outpatient settings as well. Different treatments for one or more cancers are assessed, procedures, complications, and survival, and compared across physicians or hospitals. There are a number of different types of registers. The most simple one known are statistical registers in cities and death registers in countries, states, or even cities that provide numbers and statistics on birth movement, life expectancy, causes of death, and analyses of temporal trends in these figures. There is an increasing area of patient organization registers that assess living situation of members of the patient organization, not exclusively members, but also with this specific disease, their socioeconomic situation, utilization of healthcare, quality of life. They sometimes collect biomaterials such as blood or for further analysis on scientific purposes. And we'll hear an example given by Lara in a minute. And finally, there's a larger area for pharmacovigilance registers to monitor adverse and serious adverse effects of treatments in patients with specific diseases. In some countries, this is mandatory. In Germany, this is not mandatory to participate as a physician, for instance, as a neurologist treating patients with multiple sclerosis using one of the new biologic treatment options that came into the market only recently. In Sweden, for instance, this is mandatory to be in such a standardized documentation in a pharmacovigilance register. In Germany and other countries, this is not. Sometimes this type of register is called a phase 4 study after market authorization has been done and the drug under test is used in many patients with a specific disease. Register as such has a lot of chances. In some instances, for instance, in the area of rare diseases, it's usually the only way, the only study type that allows effectively to document cases, because a case in a city, a country, or a state is so rare that only this type of documentation enables the chance for further scientific analyses. Registers can analyze time trends in treatments, in complications, in improvements of, for instance, life expectancy, quality of life, or functioning. It can analyze disease frequencies, spatial distributions. It offers and is frequently used for quality assurance purposes with the aim to improve care, to monitor or analyze healthcare utilization, and therefore forms a basis for economic analyses. The area of adverse event reporting is under the headline of patient safety for different treatments, especially those who are new in the market, and in some occasions also to analyze efficacy of specific treatments in groups which are rarely included in clinical trials, so-called phase 3 trials, such as either the very young children or the very old, or individuals with in a specific situation, such as pregnant women. All these groups are usually excluded by in and exclusion criteria from phase 3 clinical trials, but also sometimes need treatment. And finally, registers offer the opportunity of hypothesis generations for further clinical research, which might result at the end in a new phase 3 clinical trial. On the other hand, we do have a number of challenges, and this is an important topic, important point, that are related to the implementation and coordination of a register. This is a very complex task. There are considerable financial and personnel resources necessary, and it is never the case that we just do a questionnaire or fill in an extra piece of paper and send it somewhere and they will type it into the computer. You have to be aware that register performance and register coordination needs usually extra and trained personnel in the areas of data management, computer knowledges, statistics, and interpretation of results. Effective management is necessary for interfaces. That is the question, how do data come into the computer? There are several informatics and data security issues to be solved, and the new European data security regulations, effective in May this year, doesn't make issues easier and have definitely been taken into account. Ethical questions, especially if additional things such as biomaterial collections are part of the register, have to be addressed and solved. Reimbursement questions for those who collect data, who contribute data, are an important point, because especially if you ask physicians who have to additionally collect data, have to do it implement that in their clinical daily routine, and this is a challenge. The quality criteria of a register are also related to data. So control of completeness of data, control of plausibility of data, issues such as how do we categorize a straightforward text information on a diagnosis such as multiple sclerosis. What is ICD code is behind that? Do we have additional information on subtypes of multiple sclerosis that have to be coded into ICD code, and so on? Who decides on cases which are not straightforward? And finally, the usual data analysis and interpretation of result is something that has to be done by someone who has the specific knowledge. Each register should have a register protocol in advance that gives information on the inclusion, on the source population, on the type of data and purpose for which it is assessed. If it's a larger one that aims for a longer time, it should have an advisory board and quality assurance measures to be implemented in the data collection routine. There are a number of information sources out there in the published literature that are easy to access. I found those three listed here very helpful, either if you start to become more familiar with methodologies for registries, or even if you're an advanced user. I divided those sources into languages, English and German. The Effective Healthcare Program Registry for Evaluating Patient Outcomes is something I liked a lot. In English, there is a series of articles that had been published quite a while ago in JAMA. If you're German speaking, you might go on the homepage and the webpage of the German Net for Healthcare Research. There are a number of instruments and publications listed there. Most of them are for free, that give you further reading into methodology and problems of registries. So far my part. Lara, I hand over to you now.
Hello everyone. Greetings from a very beautiful snowy Paris. I'm usually in London, but I'm actually in one of the most beautiful cities in the world for an EDS conference that's happening tomorrow. So thank you, Klaus, for that great introduction. I'm going to talk to you on the agenda. It kind of indicated that we have been successful in completing our registry, and I just want to clarify that we have not, and we are very much in the process. So I'm kind of speaking to you knee deep in registry issues and the complications that can arise when trying to do one. And I can give you advice that we have to consider and things that we had to think about that perhaps we did not think about beforehand. So let us begin. I'm going to give you a little bit of a historical context to help you understand how we got to a place where we were ready to build this kind of thing. EDS has had about 20 years of neglect when it comes to research and published materials, and that's really become evident in how patients are being managed and treated. And we do have quite a unique spectrum of issues within this condition that you do see in other chronic conditions, but we have suffered these 20 years where there was no update of our diagnostic criteria. The last one was done in 1997. And so everything has come a very, very long way in a very short space of time, and I'll talk you through that. So back in 2012 in Ghent, there was the first kind of group meeting of international specialists that were dedicated to this condition. And there were attempts to discuss updating the criteria. Nothing really happened until there was a meeting again in Glasgow in 2015, where I was at the time running EDS UK, and I was working with EDNF to try and make this international symposium happen in New York in 2016, with the intention to reclassify EDS and publish management and care guidelines for the first time. So I'm delighted to say that that happened, and out of that there was this realization that there needed to be a global organization to oversee that this happened regularly and that there wasn't another 20 years of neglect. So in May 2016, there was the creation of the Ehlers-Danlos Society, and at the same time the formalization of the International Consortium on Ehlers-Danlos syndromes and related disorders. So the first time ever, we've got a very strong foundation and platform in which to do some great research to really progress further in the genetics and the things that we're learning about this condition. And our next international symposium is in September of this year in Ghent, in Belgium. So what came out of that was 18 papers published in the American Journal of Medical Genetics in March of last year. It was authored by 96 medical professionals. And as I said, there was a 20-year wait for this. Some big things to happen were we went from 6 different forms of EDS to 13. We know the mutation for 12 of those, and the most prevalent hypermobile form, we don't yet know the genetic markers for those. We think there will be more than one gene responsible. And hypermobility spectrum disorders were introduced for those that no longer met the now stricter criteria for hypermobile EDS. EDS now does still all fall under a rare disease, and HSD is thought to be common. And as I previously said, for the first time, we now have management and care guidelines across all the different comorbidities that can come with this condition, and there are many. So with that information, we realized that what was needed to really take things forward was a registry. And when we began in 2017, we thought we would kind of bring everything together and do the discovery and the collating at the same time. So the initial plan was we were going to try and do discovery into what the hypermobile gene was, genes, and we were going to do bring together whole exome sequencing that had previously been done and possibly create an EDS or connective tissue panel. And we were going to do whole genome sequencing. And we were going to bring that together, hope to find the genes, and at the same time, collate existing known mutations. So we knew more about the rarer types in terms of the epidemiological side of things. Collate existing hypermobile sequencing that had been done so that we can see if we'd missed anything. And at the same time, do this patient-led social science study. Very quickly, we realized that we were trying to do too much at one time, and it was kind of blurring the lines of going back to what actually is a registry and what do we need to get out of it. So we've simplified things massively, as you can see, and in 2018, we're progressing with this idea that we need to build this registry. We need to have genotype and phenotype information for the rarer forms, and we need to have very good phenotype information, and one day we hope genotype information for hypermobile EDS and hypermobility spectrum disorders. And so that's how we think it will look at this stage, and we will of course be working separately on discovery for the hypermobile gene as we go forward, and really trying to expand our knowledge in the genetics. So that will happen as well, but it was kind of becoming a bit muddy that was part of the registry, and it's important to define, and as Klaus spelt out, that's not, you know, in its purest form, it is a collection of data, and we need to remember that. So for those, by the way, that don't understand the zebra reference, our kind of mascot and branding is a zebra, and that's because medical professionals are taught when they hear hoofbeats, think horses, not zebras, because that's the kind of the rarer health conditions, and we're trying to constantly remember to think zebras and not just horses. It also signifies that not every zebra has the same stripes. So every single zebra has different stripes. Most people with EDS have different symptoms, but when you see a zebra, you know it's a zebra. We want to get to a stage where you see someone with EDS, you know it's EDS. So that's the reference to the zebras. And you can see that this has caused us, from this picture here, a lot of stress. How do we input this data? Because there are two clear options that we could see. And they were for it to be clinician-led or patient-led. Now, there are clear benefits and drawbacks to both options. With the clinician-led option, you have the great benefits of it being reliable diagnosis and phenotyping. You also know that that data is validated. So you know if someone has a certain type and certain comorbidities, you can rely on that. But then there are some negatives with that. So there's a geographic bias near clinics. We know that there's not EDS specialists all over the world. And within countries, they're normally like concentrated around London, for example, or in East Coast in the USA. And so you wouldn't have a true kind of demographic information there on really who is suffering with this. So you couldn't really do true epidemiological studies to work out prevalence. There's also the issue of clinics being totally overwhelmed. Some of our EDS clinics have 2 to 3 year waiting lists, and those clinics are already overwhelmed. So how would the staff have time to then input all this data? And also you've got these patients that are waiting this length of time, so it's going to delay how quickly that data can get on. And then you've got, like I said, a demographic bias, because there's often costs to attend clinics. In the US, there's, a cost to healthcare. So are you seeing a true spectrum of those who are affected? And in the UK, you've got the private clinics where a lot of people are being seen, but then there's a lot of people not being seen on the NHS. And, the burden goes on and on across the world. So it's limited, but it's reliable. That's the issues with it being clinician-led. And then there's the obvious, which everyone thinks it makes perfect sense, that it should be patient-led. It's relatively easy. There are excellent surveys that you could do, and ways that you can ask the same question in lots of different ways, so you can try and validate that data as much as possible. It gives you a geographic spread. It gives you a spread across all the different demographics, gender, age, wealth, everything that you could imagine. You get that access to anyone, wherever they are, being able to input their data. The biggest issue is, and it's huge, is that data is not reliable. Issues that come up in Ehlers-Danlos syndromes are because of this lack of education and this neglect that had happened for so long. There's people that are still calling them different things. Someone somewhere may be diagnosed with hypermobility syndrome, someone somewhere else joint hypermobility syndrome, someone else hypermobility EDS, JHS, benign hypermobility. Someone could be told by someone who really doesn't know what they're talking about that they have classical EDS and hypermobile EDS. And the list goes on of the limitations to this being patient-led. So someone could, think, I'm quite dizzy, I have the symptoms of some autonomic dysfunction, put themselves down that they have POTS, and how can we rely that that's actually reliably what they've been diagnosed with? So we had to really think about what we can do. And to be totally honest, we don't yet know the answer of how we're going to validate this data. As we know, bad data equals bad everything. So if we go for the easiest option and the option that will get as many patients on there as possible, we're not necessarily going to get anything that's worth studying or giving us true indications of really the prevalence of this condition. And ultimately, we are doing this, we're building this registry for research and to find out more. And we just can't do that with wrong information. So something that we have decided to do through the International Consortium. The International Consortium is made up of committees that represent each of the types of EDS. So we have a hypermobility committee, classical, rare types, vascular. And then we also have groups, working groups for all the different comorbidities, such as GI, neurology, pain, psychology, and on and on. And what we have tasked the consortium to do over the next 12 to 18 months is to come up with common data elements. And common data elements mean that the information that we are getting in is much more reliable. So if one doctor in the UK is saying this patient has stretchy skin, how do we know that a doctor in America or India or anywhere else is actually measuring that and assessing that in the same way? What is stretchy skin? What does it mean? What does pain mean? All of these different things that are so important, and it's such a vast spectrum of this multi-systemic condition that we have to standardize this somehow. And so we've gone backwards. We're kind of saying, okay, we know we're building this registry, we know what we need to do, but in order to do that, we need to create these CDEs, and we need to do that. Then they become available in the NIH, so that it's this kind of repository that is available to anybody anywhere, and we can start to build something that is standardized and reliable. We still then don't solve the problem of it if it is being patient-fed, how that is reliable. We know that if they've gone to a clinic and they've received that diagnosis and they're using the CDEs that we've recommended, sure, that's reliable. So we still are very much in the working process of making sure we make the right decisions here. In terms of money, it's a very important consideration, especially when we're talking about patient organizations that often have very limited funds to make this happen. And one thing that we were quite pleased to realize is actually the platform to build a registry can often be free. So there are lots of great free options out there. You can do some research, and that, you know, they are as complex or as basic as you need them to be. Again, on the whole, they are set up to either be clinician-led or patient-led. More and more it's patient-led, so there is more and more evidence out there for, if you ask patients questions in the right way, the data will be reliable. So it is changing, the landscape is changing rapidly. So we hope that by the time we're ready and we have our CDEs, that there will be even more evidence out there for there being a case for this to be patient-led. You then, as Klaus indicated, you have to think about staff costs, how you're going to manage this process, if you're pulling in data and sequencing, how that will be analyzed and how it will be managed. There's the implementation costs, and ethical and data security and all of these things. And then there's also, if you're going to decide to do the CDE process as we're doing, that takes a hell of a lot of time. Again, it's not a cost as such to create common data elements, but we have colleagues at CSF who have just kind of coming to the end of completing their process, and it took them 2 years to do that. So we've kind of planned for this to take around 18 months. It could be done quicker, but you have to let the time happen. You were talking about huge amounts of common data elements that you have to think about. So that takes time as well. So it's important things to think about. It's sometimes the simplest question, like, you know, how do we make this data reliable, that you have to think about? And there's no obvious answer. There's plenty of people out there and platforms and different companies that are there and willing to give you suggestions. But ultimately, it does depend what kind of patient community you're talking about. If if it's a condition that you know all the genetic information for, it's a much simpler process. And it could be patient-led. You know, you have the ability to upload tests and genetic results and data from sequencing and all these things that make it really very much evidence-based what you're putting in there. So the different complexities come with different conditions, and I think it's just important to think about how important it is to make the data that you put in as good as it can be. These are my contact details, so if anyone did have any questions or queries and they're doing the same journey, then I'd be happy to help. And that's all from me. Back to you all.
Wolf, are you there? In the absence of Wolf, I'll take over. This is Matthew May, and program coordinator of the EUPATI program these days. So if you have any questions, do go ahead and ask them, and we'll be going through the question panel just now and asking questions to both Klaus and Lara. They can be specific about their presentations, or they can also be just a question you have based on your own experience. Maybe you've been looking at doing registry within your area, have some experience to share. So I see one from Joan Jordan. Maybe we'll direct it at Klaus. The question is, do registers ever have levels like tracing from regional to national to European to global? Does this exist anywhere, or are they very much restricted in the way that they're set up?
This is the ideal case. I'm aware of, in the area of stroke, where there's a modular approach where some registers documenting treatment on stroke units nationally merged or agreed to pool data on a European level, which means several countries, organizations in these countries have agreed to do that. I'm not really aware of a modular approach that reaches out globally. But a lot, if things are, the rare a disease is, and Ehlers-Danlos is a good example, it makes less sense to start an own initiative for the X number of cases in my country. So cooperation on a European or an international level and makes much more sense. The more frequent a disease is, the more sense it might have to start a local or regional initiative, especially if healthcare systems differ in their approach to treatment for that and diagnostic workup for that specific disease.
I'll just add to that all the options we have been looking at have been a global registry. So it was very important to us, as I alluded to in the presentation, that all of the effort that we've been doing is very much on an international platform, and that's how we wanted the registry to be. And all of the options that we looked at did have the ability. You've got, you know, cross-border ethics to consider, and some things will need to be managed differently, but it is possible to do a global registry.
Super, thank you both.
Communication.
Yep. Yeah. So an important question here, and one that I know from my side, I'm beginning to have headaches with our various IT platforms here at EUPATI, is how do you handle the good data protection regulation that's coming in? So data privacy aspects of patient-led registries. How have you gone about planning those and dealing with them, Lara, from your side?
Well, most of the options that we've been looking at do take that into consideration. So a lot of the platforms that you have that kind of safety net there, so to speak. But that's when the concept of it being global becomes much more complicated, because every country will have different regulations and different standards to adhere to. So as long as you're making sure that you are complying with all the different countries that you're receiving data from, there are pretty simple ways of implementing that into the journey for the patient to enter their data. But it's important that you know, plan that ahead, and it is as important to the journey that the patient is going through on that registry as, for example, you know, filling out some of their symptoms and medical history, etc.
Yeah, and of course, those of you who are familiar or a little bit familiar with the Gdpr that's going to come into effect in May, health is obviously what's classed as sensitive data, and so has extra, I guess, I won't call them hurdles, but extra requirements that we have to look into for the purpose of data protection and the platforms that contain them and how you transmit them across country borders. And as Lara says, that has to be also on a national level. Even if we sit in the EU and have our registry based within the EU, we need to be compliant with all of the countries of all of the different people who are present in the registry. So, next question.
I do have can you hear me now?
Yes, go ahead, Wolf.
Oh, well, okay. I have a comment, really, comment and question is from Eric. Okay, patient-led may lead to bad data, but not always. If you participate as a patient organization, you can contribute, and you can also organize trained people.
You can, but when you're and you're right, it doesn't, patient-led doesn't always lead to bad data. You're absolutely right. But there's no real way to know what is bad data and what is good data, and I think that's the issue. So yes, when it's patient organizations doing it, but the idea for us is that we would roll that out. It would be a level on our website where people could come in and fill out their details, but there's no way of us controlling what data that they're putting in is reliable. It's all about how you ask the questions and how you kind of gather the phenotypic details, and that's where the CDEs come in that will really help us. And there are lots of ways, like I said, of asking the same question in different ways. So you're not like tricking the patient, so to speak, but you are trying to really narrow down to get that information. One other solution that we are thinking about, and that is often done when it's patient-led, is that you almost have a filtering process. So you, as the patient organization, you're responsible for getting in as much patient information as you can, whether it's like socioeconomic process of how they got to their diagnosis, all of those things that are very helpful to an organization, but perhaps not for research. So you get that information, and then there's another layer where you've got patients that have backed up clinic letters or diagnostic reports or things that you know that you can rely on and that are validated, and so on and so on. So you're almost creating this sieving process, so that what you end up with is maybe thousands of patients on the bottom layer. And so, for example, in EDS, when it's not one of the rarer types, perhaps it would be that everybody that doesn't have validated information from a doctor, for example, is all in the HSD pool. And this is just an example. And there may be many in there that have hypermobile EDS, and they may be diagnosed with it. But so you then take them up a level, and it's like, okay, so where did you get your diagnosis? Was it pre-new criteria or post-new criteria? And so on and so on and so on. So those maybe 8,000 patients end up being 800, but those 800 are incredibly reliable and validated. And so it is through that patient organization that you have managed to do that process. And that doesn't make all those 8,000 redundant and useless, but by no means. The idea is that you're constantly doing research to be able to kind of draw more and more people out of that group, so that you do get to a point where everyone has that kind of validation and clinician-led reporting that they need and deserve.
Lara, there is a follow-up almost to this. Stefan asks if you can give a proper example for a CDE. If I understand you correctly, you would define a CDE and then sort of filter the incoming information from this large group of patients and check if this fits your CDE. Is that so? And
yeah,
can you give an example?
Sure. So there's one good thing about this process is there are a lot of CDEs that have already been done. So for example, most of the demographic CDEs, gender, age, all of those things have been done. And it's how to ask those questions so that you know that everywhere you are, you're getting them you're reported in the same way. And so, for example, the example I used in EDS is one thing that always comes up is, how do you measure stretchy skin? Something that is often written on patient's record, patient has stretchy skin, yet that same patient may go to another doctor and they don't find that they have stretchy skin. So we need to have a data element of how do you measure stretchy skin? What do you input as the result of that? And how do you measure it? And so on and so on. So if you go through, how do you measure dysmotility in the gut? And that's the idea of it. And so if you imagine all the different comorbidities across EDS, and then within those comorbidities, all the different questions, that's why it's such a huge task. The one good thing, though, like I said, is because of those different disciplines, there is already work that's been done. So for example, with CSF, they've already done a lot of the neurology questions through their process. So with our neurology group, there's a lot that would have been asked already, but for example, in tethered cord syndrome, there haven't been. So that, they'll need to fill in the gaps. So part of the process we're doing is working out what is there, then working out what we need to create, and then following on next year, we will then work on the process of creating them. And we would really recommend that process to anyone kind of in the rare disease world or living in this, because that's the future of standardizing these kind of things.
One could continue this discussion with the next question practically. And that is a question on whether you, at least I interpreted it that way, whether you really pinpoint two very specific CDEs which you have predefined, or take in other information as evidence. Eric asks, how can you organize so that patient and/or patient organizations can have input into registered things, so that registers are also including patient experience or relevant things according to patients?
Of
Well,
course
for
you
us,
can.
I mean,
Klaus?
for us, sorry, go ahead, Klaus.
Okay. Of course you can. The question is what Lara mentioned in her example. How do you get access to the patient, and what type of information / experience do you want to collect from him or her? And this goes, if you look at it from a broader perspective, this goes back what I tried to explain what is the purpose. So which type of experience with physicians, with the healthcare system, with daily problems, activities of daily living, in specific disease stages you want to collect, ? And if this is clear for those who organize the register or coordinate it, then you can of course choose the right questions or scales which measure what you intend to measure, integrating this experience in addition to, say, diagnostic or physician-based workup reports and so on. A further comment to the question before is the filter issue. If you go back and only ask patients, of course you will have a certain amount, especially if the diagnosis is hard to make, which have everything but the diagnosis of interest. So if to come down from the 8,000 to the 800 is a process that could be done based on all available data sources, physician reports, subjective history reported by the patient, additional results of workup on a local or national level through some institution like patient organization. You can, of course, also organize that the register in the first step serves as a collection machine where patients who are willing to do that send in all this information they have access to, but then behind the first step and the second step, you must organize that this information is screened and classified. That's the point I try to address with classification problems, so that you ideally filter out those homogeneous 800 who would fulfill the same subtype or same diagnosis. This is a question of resources, of money to organize that, and on data security issues that patients might be willing to upload or send, however this is organized, their personal information on their disease state to an address where the registry is.
And I would say in terms, I was just going to say in terms of patient involvement, I think what we learned from this process in terms of writing the papers, creating the consortium, and now the work on the CDs and registries, it's so essential that you have both clinicians, researchers, scientists, and the patient voice involved in the whole journey, because you then feel like, which is everything that EUPATI is about. You have to feel that the patient is around the table as a stakeholder and that is considered for decision making. And if that happens from the beginning, then you shouldn't run into the problems of patients feeling like their questions aren't being asked in the registry. And so in every committee and every working group, we have a patient representative in each of the groups. And for that very reason, that we want this to be fulfilling not only for research, but for patients to feel like they are getting out the information they want to share.
Mm-hmm. There are numerous questions as to, is there something like a gold standard registry? I would interpret it as registry type in Europe. Both to you, Lara and Klaus. I personally don't know.
There are gold standard. different types of registers and for different purposes. There is a funding initiative by the German Ministry of Education and Research currently ongoing that tries to implement standards which I showed on quality for clinical registers for various diseases. This, and that's the hope by the minister, will change the landscape of clinical registers in terms of quality in Germany. There are, I would put the question otherwise round. So the purpose for a register first, and if you tell me the purpose, then there are a number of gold standard existing registers fulfilling this specific purpose, but not for every purpose there is a gold standard available.
There's another interesting question coming along by John, and that is probably also related to what we briefly touched upon, the new GDPR regulation. Is it usually a legal requirement for registries to have an ethics policing mechanism in place or policing mechanism in place? Good question.
It should. It should. I'm pretty sure 80% do not have, or even more, but the proportion of registers, especially if they are on a larger level, that is, for instance, nationwide, they do have either an ethical board or an ethics concept, which allows them more easily to deal with potential ethical problems that might arise from data collection, which is not so often the case. This is more data security issues, but also from data or biomaterial analysis. We just learned from Lara that genetic analysis, GWAS, for instance, is part of that register, and this has another component or a dimension of ethical problems that might come up. And to be able to answer these questions, an ethical framework that must be specific to the register should be set up in advance or prior to the problem.
Mm-hmm. Lara, anything to add to that?
No, not really. I think yeah, you said it all really.
Yeah, there's another question also, again by Eric, which relates to how do you deal with the input you are receiving, and how do you deal with the people who are providing input to registries? Question is, are there opportunities to give more direct benefit to contributing patients? For example, feedback or providing summaries, or the opportunity to contribute to the register by means of apps or social media platforms.
I think that
go ahead, Lara.
Yeah, Lara first, then Klaus. Okay.
I think most registries can be accessed. I think there's ways to turn them into apps. That certainly ones we've been looking at that can be accessed through apps on your phone or through a desktop. So yes to that. Again, with social media, you don't want to rely on the social media providers or platforms because they will not have the capacity and capabilities that a registry platform would, but you can certainly access them through social media. So we certainly plan on promoting our registry when we have it through those means. And I think that in terms of patients getting feedback, I think that's quite unusual, and I don't think we plan on doing that because it makes no sense to do that. But what the feedback would be research that would be coming out of the fact that you've contributed to that data, and that would be the ultimate outcome for me that I would want to see as a patient giving in my data.
I would add here, also relates or includes the question, how can patients be motivated to contribute data to a register? And here's feedback. Of course, one option, and feedback from a register can be only results, and that's where research comes in. Results from research that is based on the register data is one option, and this is not so rarely done if research is actually been done in a register or by scientists that are collaborating with that register. And this is one effective measure to really motivate people. But in that case, the prior question on ethics, on the framework, or have an idea on ethical problems that might arise is even more important, because especially if you have research done in the field of genetics and send this back even in lay understandable language, this might generate ethical problems or at least questions. So this is a twofold issue. It's important, and it's one measure or one option to increase motivation to contribute. On the other hand, it has to be carefully planned and formulated.
Okay. There's another question, which is, well, there are two methodological questions. One is, and it's obviously a very important one by Carol, how do you define validated data? Would it have to be a doctor's letter? Personally, I would say that is probably not sufficient from the start. You have to define before. Klaus.
Validated data would relate validation to a gold standard. And then the real question is, what is the gold standard? And this depends a little bit on the disease. For instance, if you take a more easy example on one of the areas I showed, that is stroke, there you would have at least a hospital discharge record, for instance, or the validation by the general practitioner that this patient actually has had a stroke. In other diseases, and we heard from Lara another example where it's more difficult to come up with a diagnosis, especially it might take several years until the correct diagnosis is done. The gold standard is more difficult to define, and the more difficult it is, the better it is to have a specialist diagnosis done. So if you can rely on a diagnosis that has been given by a specialist, then this would be defined as a gold standard, for instance, in the area of Ehlers-Danlos, or in the area, for instance, of multiple sclerosis, because this information integrates several single diagnostic workup approaches that have to be done before you can actually come up with that diagnosis.
Mm-hmm. And I think, just to add, again, it's different in every condition, and it's different within. Mm-hmm. Yes, for example, the 12 different types. It would be one letter from a geneticist with sequencing results would be sufficient. But in the hypermobile type, where there's all the different multi-systemic issues, you would need test results, scan results, tilt table tests, a clinician's letter, a Baton score workup. It's very hard to answer that question because every single condition would be different.
Yeah. Okay. There's a question by Alan who says, when you are working towards a global registry, are there any issues found relating to time zones? Interesting question, I find.
No, because it's not something that is I don't know, put it, no, because you can access it. If someone wants to, if it is patient-led, for example, and someone sitting in Uruguay wants to fill out their registry at 3 o'clock in the morning, there's absolutely no reason why they can't. The only time it would become time sensitive is if it is clinician-led and you're doing it within clinical hours. But again, that still wouldn't be a problem because there's no time limit. It doesn't switch off. It's an open platform. So no, I can't see time zones being an issue.
Mm-hmm. There are two questions in one by Kirsten. One is, how do you solve, and well, that again goes to both of you. How do you solve the data protection aspect and genotyping?
Well, each collection of data, and especially biomaterial, has to solve ethical problems, questions arising, and data security issues according to the national laws. The example in Germany would be that if we start a new register here, let's say a clinical register at the University Hospital of Münster, recruiting patients with a specific disease, and we plan also to collect blood from them to later analyze genotypes, then this would require an application to the ethics board and a clarification with the data security officer here. And this is basically the case all over Germany and in most other countries, at least in Europe. The potential to re-identify an individual based on his or her genotypes is a different question that's implemented in there, because the personal data items, the personal information, that is name, address, and so on, so that you can trace back a combination, a specific genotype to Klaus Berger, has to be made impossible by providing pseudonymization or even anonymization of those contributing to it. So if you can only trace it back to an ID of 1, 2, 3, 4, then you don't know who the person actually behind that ID is. And this is the way things are usually solved.
Mm-hmm.
Lara?
Nothing to add.
Anything to add here? Probably not directly this. There's a question which in a way relates to them. Is how difficult is it to comply with the new EU Directive for Personal Data Protection, and what are the implications to establish a registry including non-EU countries? That is not an easy one.
Yeah, it's a long one.
Yeah, that's not an easy one. Matthew, would you have to say something to that directly, almost, because we have been dealing with this in a different setting, but this
sure.
is
I mean, I've been considering it from an IT perspective for obviously the IT platforms of EUPATI, the toolbox, and also our learning management system. On the most basic level, all IT software is upgrading itself to come into line with compliance. So it's mainly an issue if you were to really build something from the ground up. But even then, on the assumption that you're not actually a coder yourself, any of the IT providers you're working with would probably be aware. When it comes to non-EU countries, it is, unfortunately, Lara sort of alluded to it earlier, it is unique per country. So you really need to do the research per country. And one of the elements of the new EU regulation that's coming through is on the transmission of data between non-EU and EU countries. So that is bidirectional, whether it's going into the EU from outside or out from the EU. And all of these things need to be described in the data management plan, and there's an oversight mechanism as well. But I don't think this is really a webinar on the EU GDPR
No.
nor are we necessarily experts enough in the matter right now to be able to give you a detailed answer, but that would be a webinar in itself.
Yeah, I would support that. I don't know if Lara and Klaus agree, but we could really think as soon as the GDPR comes into effect, which is May 25, we should maybe get together and have a specific webinar on the GDPR with respect to, for instance, registries. Is that a suggestion which we could follow?
Mm-hmm.
What? Oh, there was this data security again. There's another one which I find interesting, and you have to. I have to apologize that I'm picking questions here because there are so many. When registering children's symptoms, that is from Carol, I assume you have to ensure they have legal advocate parent. How far do you go with this? Mm-hmm.
We go, if I can start.
Yeah, go
need,
ahead, Klaus.
Okay, you need signed informed consent by the parents if the children are younger than 18 in Germany.
Mhm.
Without that, you are not allowed by legal, for legal reasons. If you don't have it, then you cannot take direct information from the kid. The situation is slightly different if a pediatrician provides information on whatever treatment or diagnostic or symptoms of a youth or child, then this does not necessarily include personal information on name and so on, but just an identification number. That's something different. Then this is possible, but the parents have to sign to that pediatrician that they are agreeing that, you know, information on symptoms or treatment, whatever, of their kid is posted or sent to that register. This is one of the reasons why pediatric registers in Germany are not very frequent. There are some, and but this is a large hurdle.
Mm-hmm.
Yeah.
Yeah.
Lara? Yeah.
I just echo that it's been indicated as a hurdle that we're going to have to.
Incidentally, the GDPR stipulates now below age of 16 instead of 18. And again, that should be Europe-wide. And we'll see how the different nations will deal with this. There's another question by Renee. Could the European reference networks play a role in the development of patient registries?
You were too robotic, Wolf.
I didn't make
Oh,
it
okay.
happen.
Matthew, can you take over?
Yeah. The question is, could the European reference networks play a role in the development of patient registries?
I'm not sure, to be honest.
Klaus? I don't know.
I'm not too familiar with the network to really answer that question, but I actually did on purpose show you the quality criteria first and addressing the questions, what is the purpose of the register? So if the question on purpose can be clarified or simplified, maybe even by a network or some other structure to help deciding either set up or not a register and what is the purpose for our register, then this would be a potential help.
Mm-hmm. There is a related comment question by Max, which says, we have different systems like EORTC, EOETC, ICOM, and so on. Why not work in one organization worldwide? Did you get me?
Yeah, because most of the necessary regulations are organized nationally, and they might have different approaches, different regulations, and one of the major issues in that is data security, which is still very different handled across the world. You know, if you take the Chinese approach, the US American approach, and the German approach, 3 worlds of data security regulations are represented, and to harmonize that is not easy.
Lara, any further comment on that?
No, nothing really to add.
Okay, then there is one point which relates to, yeah, in the broadest sense to the spread of data, items one collects in a registry, and that is what will be done for data that are patient reported and based on quality of life.
Well, that's an important addition to most outcomes. So if you take the world of patient-reported outcomes, quality of life scores are one major component. And as far as I know, legal authorities in the States sometimes are very hesitant to accept this subjective measure as an aim for new medications. In other countries like the US, this is different, for instance, to the situation in Germany or in the UK. But my perception is that patient-reported outcomes as a more general area is gaining importance in the perception of the lawmakers.
Okay.
Yeah, no, I agree. Nothing really to add. I mean, yeah, I mean, you covered everything I was going to say.
Yeah. Then there is one which I am not so sure I read it correctly. It's by Anna. Close to home care need, no specific diagnosis, more focused on prevention. Have you seen anything similar anywhere else? I guess she asks her, is there anything like registries which deal specifically with questions of prevention?
I don't think, I mean, correct me if I'm wrong, Klaus, but I don't think, well, we're certainly not going into this with a specific question in mind, because then it just narrows down the purpose of a registry. I think the best kind of registry is when you ask as many questions as possible and allows you to then kind of ask as many questions on a research focus from that. So I wouldn't say that it would be a focus, but it would be something that would come out of it.
Yeah, Klaus, anything to add to that? I mean, do you have anything in mind where a registry is set up specifically in a disease area or a treatment area even for prevention?
Specifically, I'm not aware, but the area of prevention or recommendations to change, implement new preventive measures or methods might be an outcome of the analysis of registered data.
Yeah.
So this is the more likely way how prevention could be addressed by a register, not by setting it up directly for that purpose, but especially in the clinical registers where you might have a clinical register on a specific type of cancer, and you, in your analysis of these longitudinal data, you find out that a specific behavior, reduction of weight, giving up smoking, or even more complicated one, being a certain level of having a certain level of physical activity, contributes to either lower complication rates, less need of medication, better subjective health perception, better quality of life scores, then this is a finding that can be translated in recommendations that are tertiary preventive measures, not primary preventive, but tertiary preventive methods or ideas how complications can be reduced or subjective issues, patient-reported outcomes can be increased.
Yeah, that makes.
Yeah, I would just say the same, that if you do it right, then you are indirectly working on preventing anyway, because that's what the research will do.
Yeah. There's another, well, we're really nearing the end, and I guess this is the last question I can give you. And that is an interesting point, because it relates to that filtering aspect which, Lara, you mentioned fairly early on, and that is too many questions at once will put off our members. How would you break it down? It can be traumatic to report this information for some, to report all this information for some.
Well, it's interesting you say that, because we actually have found the complete opposite, and that our whole community seemed to never have survey fatigue, as we call it. And whenever we often send surveys out to our community on behalf of other researchers, and sometimes they can be 40 pages long, and we think there's no way that there's going to be a good impact on that kind of survey. And people just love to be given the opportunity to share their story and to help in a way that they can't. I think, again, it goes back to EDS being quite unique in the sense that these patients have felt so neglected. They felt like they have had no one to turn to, no options, no treatment, no medication, no answers. So if you give them the opportunity to take part in something that could help future generations and help shape research and give us answers, I actually don't think that there's a limit to what you could ask. Now, that could be unique to our community, and like I said, it's registries as a whole. There are some questions that you can ask that cut across all different kinds of conditions and diseases that is the same answer for all. But questions like this, as an example, certainly not. Some people in, say, cancer registries or something like that may be exactly what you're saying. They just do not want to reflect and go back to that, and they don't want to answer lots of questions. And so it really does boil back down to it being a case-by-case thing. And we don't think that will be a hurdle for us. We think that the more information people can give, the better. I mean, we sometimes get emails with people, giving us their medical history, just volunteering it, and we can't do anything with it, but just people just want to give us this information. And so that's our experience. And, as your questions alludes to, that's not everyone's.
Okay, well, Klaus, one last word.
It seems EDS is very special in this context. I would always recommend to if you want the same patients provide information into your register on a regular basis, say once per year or every other year or so on. For the first time, it usually is better to have all the information provided, and this can be longer. But the longer the register runs and the more often you try to get information, the more restrictive you must be in terms of items to be assessed. Our experience is with many different types of registers for different diseases that anything that goes, to give you a more practical example, that goes beyond 10 paper pages, one-sided, is difficult to get back on a high quality. And I learned from colleagues in the UK that this is different in the UK. So response from patients in the UK is much better than, for instance, in Germany, and you can provide longer questionnaires or more data items to be filled in. And this has a cultural approach too, but in general, and this goes back to one of my earlier statements, what is the purpose of the register? And you should concentrate the number of questions you ask or items you assess on this purpose and restrict. Be short, be precise, the better will be at the end the data quality for the analysis.
Thank you very much, and till next webinar. Bye-bye.
Thank you. Bye-bye.
Bye-bye.